Good afternoon, everyone. I hope you all are having a great day. I'm going to give it a couple of more minutes and then we'll get started. Okay? We still have a few people still coming in to the meeting. So just give us a couple more minutes and then we'll get started. Okay. Good afternoon, everyone. On behalf of the Ohio Legislative Children's Caucus, welcome to the March 31st meeting. I am John Stanford, State Director for the Children's Defense Fund Ohio, and it is my pleasure to be your facilitator this afternoon. Today, we have a very important topic to discuss. According to Children's Defense Fund Ohio's Kid Count 2025 data report, Medicaid is literally the lifeline for over 1.4 million Ohio children. The Kids Count data also highlights the shared health experience that many youth across Ohio face every day, from its largest cities to its Appalachian communities. Children in both settings receive comparable levels of Medicaid support. 59.7% of children in Ohio's Appalachian region rely on Medicaid. 60.1% of children in metropolitan areas also rely on that program for health care. Due to this type of need by our young people, we have to be very careful when we propose changes to the Medicaid program. There are changes being discovered right now at the state and federal levels. By the end of this discussion, we hope to provide you with information on the following. What is the current state of Medicaid use by our children in the state of Ohio? What are the current changes being proposed to Medicaid at the state and federal levels? And last, what is the potential impact of those proposed state and federal changes on Ohio's children? Presenting information to address the above questions and more are Dr. Guillermo B. Bervejillo. Dr. Bervejillo is the research manager at the Children's Defense Fund Ohio. He has extensive experience as a policy analyst and researcher focused on tax, property, and economic policy. The next panel member is Kathryn Poe. Kathryn is the budget and health researcher at Policy Matters Ohio. Kathryn has an impressive research record focused on healthcare, childcare, civil rights, and the state budget. And then our last presenter today is Elisabeth Wright Burak. Sorry about that, Elizabeth. Elisabeth is a senior fellow at Georgetown University's Center for Children and Families. Elisabeth has more than 2 decades of federal and state policy experience. Elisabeth's work is focused on Medicaid's role in supporting early childhood development and mental health while providing expertise and support to state and national leaders on Medicaid policy. For today's meeting, in order for the presenters to get through their entire presentation, I would ask that everyone hold any questions that they may have for the presenters until after the final presentation. All right. With that, I will turn the microphone over to Dr. Bervejillo to start the presentation.
All right, everybody. Thank you. Thank you for having me. And thank you all for being here on this gray Monday. Lots of activity at the State House this week. So I think it's worth just grounding ourselves again in once again in the real life experience of children here in Ohio. So in the next slide, I just wanted to give you guys the Medicaid experts are the next two speakers, but what I wanted to provide today is a snapshot of Ohio's children in 2025. These numbers are from 2024, but it gives us an idea of what these children are living through. So top headline number for our Kids Count data, which is generously supported by the Annie Casey Foundation, is 470,000 children roughly living in poverty in Ohio today. So you know, the analogy I like to use is that the stadium, the shoe fits 100,000 people. Imagine filling the stadium with children, toddlers, babies, teenagers. You could fill it 4 times over. You would still have to find another 50,000 seats of seating. It is an urgent issue. It is an urgent dilemma that we have. According to the Department of Education, half of children of the 2.6 million, so half, 54%, more than half, are faced with some kind of obstacle when it comes to learning. That's children living in poverty, but also above that, be above and beyond that, those who are limited in their capacity to learn because of economic obstacles. And a few more numbers here. 1 in 4 children enrolled in SNAP. And the key number to our discussion today is 1.4 million children in Ohio enrolled in Medicaid. I wanted to kind of, these numbers maybe don't stick with you quite as much as it might if we could think about it in their geographic kind of setting. So here, just two maps to compare so you get an idea of where these experiences are being felt. As you can see, the map on the left is the percent of children on poverty. The dark blue is where you have a quarter of children, like 1 in 4 children in that county living in a poverty situation. What you can see is, of course, in the Appalachian region, you have significant poverty, but any of our major cities, you have at least 17% of children living in poverty, and some much higher. But the one for today is the percent of children enrolled in Medicaid. The purple colors, those are where at least half of children are enrolled in Medicaid. All our cities, all our major cities, half of children are enrolled in Medicaid. But there are significant portions of the state where that figure goes much higher, and in particular in the Appalachian region. You can see the relationship in between poverty and Medicaid right there. Again, this is a key service for children across the state. It's a lifeline, as Dr. Stanford said today. But one of the things that comes out from this map is the relationship between the Appalachia and the metropolitan areas of Ohio. Many of the figures that I talked about, the children in poverty, children with economic disadvantage in learning, children enrolled in SNAP, and children enrolled in Medicaid, we see very similar figures in the Appalachian region and the metropolitan regions of Ohio. So I just wanted to put those numbers. I don't have to go through every single one, but it is worth pointing out that there's plenty of opportunity to build bridges from different parts of the state to try to create a unified attempt to improve the situation for children in Ohio beyond the partisan politics of the moment. So with that, I will cede to Kathryn, who has some amazing research on the budget and Medicaid situation.
Well, good morning, or I guess good afternoon, everyone. It's really nice to see so many friendly faces on this call. So today we're going to talk about Medicaid and the pending federal cuts, but we're mostly going to talk about how different federal policies would actually impact Ohio on the ground. I feel like it's really easy to see the things that are happening in DC on the news and not really quite understand how they connect here in Ohio. And so that's kind of the connection I'm going to try to draw. So if you're not familiar with us, Policy Matters is a nonprofit policy research institute. We do policy, we do research, we do everything in between, and we cover a whole bunch of different areas, including education and Medicaid and health policy. And I am a Medicaid and budget researcher. So Medicaid, as many of you know, cover about 3.2 million Ohioans, that is 1.3 million children, and accounts for over 4% of Ohio's economy. When we think about the economic impact of different programs in the state, Medicaid truly leaves a unique imprint. It is especially particularly important in small towns and rural areas. Our friends from Georgetown Health are here actually today, and this is one of their many statistics, but about 29.5% of children are covered in Medicaid by Medicaid or CHIP in small towns and rural areas in Ohio. So as you can see, Medicaid is a really key part of what keeps Ohioans healthy all across the board. Today, I'm going to talk about all ages. So I'll talk a little bit about kids, but I'm also primarily talking about adults and folks in the Group 8 portion of Medicaid. So I will just be focused on kids. For example, today you can see in this map, this is the amount of Medicaid and SHIP enrollment by congressional district. As Guichet previously pointed out, you can see that the Appalachian region is really, really, it has a higher than typical amount of folks. Also, our regions like Cleveland are particularly impacted and covered by Medicaid. But truly, you can see this impact all across the state. So many kids are impacted by Medicaid, but as are a lot of adults. And this working age adult population is one of the key targets of current congressional Medicaid cuts. So I do want to just like pull that out for a second. So today we're going to talk about 4 different proposals that are being proposed at the congressional level that would result in Medicaid cuts at the state level. As of right now, we are currently in the budget process. I'm sure that all of you are well aware of this. And all of these possible federal cuts will have big impacts for our state's budget now and in future budget cycles. And so first, I'm going to talk about work requirements, which is the one that I'm sure that many of you are the most familiar with. So when you think about work requirements, it's actually very straightforward. So federal work requirements for Medicaid would, as it suggests, be imposed at the federal level, and it would model after a lot of current state policies that also do just that. So it's very simple. It would simply require someone to show some kind of proof of work, whether that is being in school or volunteer activity, in order to qualify for Medicaid. State proposals also follow this model. And while it might seem very, very simple, that you should simply have to work to receive healthcare benefits, this is actually not necessarily the case. So Medicaid is primarily, the primary goal of Medicaid is to provide low-cost healthcare coverage to individuals. It was not designed as a workforce program from the outset. And although it might be tempting to pull it into being a workforce program, what we know is that this just isn't effective. So I often joke that in public policy, it's very difficult to find an example of a policy where all of the data gives us one strong picture. But this is actually that policy. Georgia, New Hampshire, Arkansas, all of these places that have had previous work requirements have really shown that work requirements are not generally effective. You know, the goal is to really get people into work, but what we've really found is that Medicare and Medicaid and healthcare access are key for getting people to work. And so without that stepping stone of health insurance and the ability to take care of your needs, get your prescriptions, it's often really difficult for people to actually transition into work. And there's a lot of really excellent data on this from across the country. But this is really, I don't believe, a controversial statement, especially when you're looking at the data and the research to support why these would be harmful for Ohioans. Next, we have spending caps. So there are 3-ish proposed spending caps and different ways that they would work. So the idea of a spending cap is very, very simple. It would just simply cap the amount that the federal government spends on something. So a per capita cap, which would be a cap on the state government, would mean that the federal government imposes specific fixed amounts of funding. This could also be referred to as like block granting that funding on a state government. So let's say you are a state like Ohio, you typically receive $100 million. That's a very low number. That's not what we get. But you receive $100 million and you suddenly have a substantial rise in the amount of people who need services. That $100 million number is set. It does not expand. And it can really strain states' abilities to meet demand, especially during significant economic downturns. Then you have a overall federal cap, which again would pay a fixed dollar amount. This would not change based on enrollment. This could also be done through capping the FMAP, but ultimately it is, again, a cap. It does not adjust, and that can cause substantial strain on states. And then lastly, you also have lifetime spending caps, which are to the individual. So typically, the problem with this is that if you have someone who has been on Medicaid for a number of years, it could suddenly say kick you off of your coverage if you've exceeded the allotted time that a state allows for that program. It could also be done in cost. So if you exceed a certain amount of cost, which would have been typical in the pre-ACA era as well. This is something that could really impact people's ability to stay on coverage, especially if they're experiencing long-term economic instability. And I really like to point out that almost every single state in the country would have in some way gone past all of these different kinds of caps. There's a lot of research testing out whether states would be able to withstand some of these changes. And typically in a state like Ohio, you would have blown far past what a typical cap would be, which would have really limited the state of Ohio's ability to actually get people covered and would have forced us to restrict the amount of people that we can actually have on Ohio Medicaid. So you've heard me talk a lot about Group 8. I always like to emphasize this is just the fancy name for the Medicaid expansion group. They're the same thing. They all came from the same bill. This is coming from the ACA. And there's also this language that you'll hear a lot in Medicaid spaces called the FMAP. This is just a very fancy way of saying the percentage that the federal government pays toward a service. So in Ohio and all around the country, this Medicaid expansion group, which is primarily adults who are of working age, many of whom are already working, we are paid for their services at a 90% match rate. That's about 90 cents on the dollar. And what this does is it was a very sweet deal for states when it was first proposed, because it means that the federal government is taking a lot of the money off of the shoulders of the state. And so the state has to spend less in order to insure these individuals because the federal government is paying more. However, some of the current cuts that are being proposed would, as I said previously, lower that FMAP percentage, particularly for the Medicaid expansion group. If that were to happen, it would be simply a devastating loss. And there are a lot of questions about who would actually have to foot the bill in that situation, because it would leave a gap in our current state budget. So as many of you know, there is actually currently proposed language, which I think is on the next slide here, in our state budget that actually has directly to do with this proposed cut in the federal match rate. So in the current state budget, there's language in section 12670 that could result in losing their coverage. Because the way that this policy would work is if Congress lowers this FMAP rate for the whole country, for Ohio, the state of Ohio would be able to immediately pause or eliminate this coverage. As of right now, it's written that it would be completely eliminated, even if the FMAP rate was to drop so much as 1%. And I like to emphasize to folks that an FMAP reduction of 5% is very, very different than an FMAP reduction of 15 or 30%. At 15%, it would still be a more substantial cost to the state, but it might not break the bank, right? And so a full elimination of this kind of language in our budget really just sets us up to, in a situation where Congress does reduce the FMAP, it doesn't allow us to reevaluate our options and take a moment to realize and think about whether or not we can, and the amount of money that we could possibly put toward protecting folks' healthcare for even 6 months more. There's also other language in the budget. This is in section 12610 that would impact spending across all federal programs. This language is a little bit looser. It includes a lot of that, what I would refer to as like ability to choose language, where the state could actually kind of shift through their possibilities and they would have choices about whether or not to pause or to eliminate this program altogether. But that federal programs language could also be applied to Medicaid because it is a federally funded program. So there are actually two trigger language pieces in the current budget as it stands. And then lastly, we're going to talk about taxes. So states are allowed to levy taxes on healthcare providers. This is a part of, Medicaid standards across the entire U.S. And in Ohio, we have four, and they generate about $2.5 billion, or at least they did in fiscal year 24. This includes the hospital franchise fee, the health insurance corporation franchise fee, a nursing facility franchise fee, and a franchise fee for immediate care facilities and people with intellectual disabilities. And the core purpose of this tax is not only to raise money toward a Medicaid program, but it also has the dual benefit of drawing down additional federal dollars. So for every dollar we raise, the federal government matches that. And together it brings in about $9 billion of spending for the state when you combine the federal match and the state dollars that you actually tax from the fee. And so these are very, very important for adding additional money into our programs. And one of the current proposals from Congress is actually to eliminate or change the way that states can raise these taxes. If they were to eliminate the ability for states to raise these taxes, it would also be a substantial Medicaid cut because, again, you're restricting the amount of money that you can bring in for your Medicaid program. They could also change the type of taxable entity. They could change the percentage they are allowed to raise from these taxes. But either way, no matter how this is adjusted or decreased, it would result in losses to our funding stream for Medicaid if it were enacted. So, just to bring it home before I pass it on, Medicaid expansion supports a lot of jobs in our state. A lot of people rely on it. For example, I always talk about my spouse is a coffee barista, and she and her coworkers are recipients of Medicaid typically. And that is why they're able to work in places like coffee shops or restaurants. It's because they have Medicaid access. And without these kinds of workforce supports, not only is it really difficult to get on Medicaid, but it's difficult to maintain that coverage. And so we're really, really trying to emphasize job growth and job security in Ohio's economy. Medicaid is really a core pillar to having success. And so any cut in any form to Medicaid jeopardizes our workforce in Ohio. And I will pass it off.
Thank you so much, Kathryn. And Kathryn and Guillermo both did a really great job sort of setting up what I'm going to try to do is illustrate more what the magnitude of the cuts on the table are in Congress. Just not to add, to reiterate again, I think there are Kathryn's last point was so important about the expansion. And I think we know Medicaid's reach for kids in particular is, nationally in recent years, it's been almost half of kids. But a lot of parents have been covered by that Medicaid expansion. And we have a parent talking on a webinar in a few days from Michigan. She's an adjunct professor. Her husband had a job with a local company. Their daughter was already on Medicaid because she had a severe disability. But when her husband's job was relocated, they had to get on Medicaid to make sure that they could pay their bills. And the way she puts it is both for her daughter and for their family, it's really been a lifeline to make sure they've got coverage during what's an already stressful time. So these things work together to help families overall and certainly kids. So on the reach, I'll just also reiterate some of what Guillermo said, which is important. In Ohio, I know Medicaid covers, I believe by Ohio's numbers, more than half of all births. Nationally, it's 99% of kids in the child welfare system, half of all kids with children with special health care needs in this country. Its reach cannot be understated for kids and families. And this summer, Medicaid's going to be 60. It's 60 years old almost. And based on what Kathryn sort of put out there about congressional conversations, this could be the most impactful year in Medicaid's history. It is really, really possible that we, without a lot of education and raising awareness about what these cuts could mean for families, we might have a very different looking Medicaid program in future years to come, and not the same kind of safety net we've seen for families for so long. So what we've seen, speaking of 60 years old, in its long history, we now know from economic studies in the last 10 years or so that Medicaid is an investment for kids. You know, while we might not think it's perfect, and there's certainly ways to improve it for access and other reasons, children who were in states that expanded Medicaid coverage earlier than other states, when they looked at states that had expanded income levels, and I don't mean adult expansion now, I mean income expansions for kids. When kids got Medicaid coverage compared to not having it, they had better, not only health outcomes by the time they got to adulthood, they had better educational outcomes, better high school graduation rates, college graduation rates. We've also seen those studies suggest links between Medicaid access and earnings. So that's the next slide. For kids whose moms were pregnant and used Medicaid, or they had childhood Medicaid, we know each additional year adds $1,700 of wages for women and additional tax payments. That's for every additional year of Medicaid as a child. That can be really, really powerful as a return on investment. Next slide. I also wanted to just talk a little bit more about the expansion, because often some of these congressional proposals are talking right now about, you know, how do we prioritize children, and maybe the expansion's covering the wrong folks. The expansion has been very, very important for children. And one piece is that it's made sure more women are covered before they get pregnant, and that means healthier pregnancies, right? So states like Ohio that expanded Medicaid have lower uninsured rates of women who are in childbearing age. And then they have that coverage. They're not bringing, you know, issues that haven't been addressed by the healthcare system to their pregnancy, and that leads to better birth outcomes. So what we've seen is, compared to non-expansion states, states that have expanded Medicaid have bigger decreases in maternal mortality and bigger decreases in infant mortality and maternal morbidity. So that's important. The other thing I would say about the expansion, in addition to that, is that a lot of people who care for children are accessing Medicaid through the expansion, or because they have a disability. So in Ohio, we know more than 30% of the childcare workforce is covered by Medicaid, right? They're typically lower income, low wage workers. That's typically the folks who are on expansion. And they might work for small childcare centers that just can't afford the cost of healthcare. And Medicaid fills an important gap and keeps them healthy while they're also taking care of children. So next slide. Oh, there it is. I accidentally, there's the slide that I just talked about. So that's been really important. And actually, in states that have expanded Medicaid, it's dropped that uninsured number for the childcare workforce to under 10%. Next slide. So Kathryn mentioned some of the proposals on the table in Congress. And just to be clear, what Congress is doing right now is they're trying to agree, the House and the Senate are trying to agree on a target number for cuts. Now, the proposals that we know were on the table that Kathryn walked through, those are because we've seen those proposals before, but also because in January, the House Budget Committee, the media leaked a menu of some of the cuts they were considering and some of their estimates of cost. So that's why we know kind of what might be on the table to make these cuts. The other reason we know Medicaid's on the table for cuts is that the House resolution that passed for reconciliation had assigned $880 billion to the committee that covers Medicaid. And Medicaid's pretty much the biggest area to get cuts in that committee. So it's pretty simple to say we expect to see, at least if the number that the House passed, that $880 billion, that's going to be a lot of money. On the Senate side, they haven't yet passed a resolution with Medicaid cuts. Theirs didn't, but they're trying to agree on a number. And once the House and Senate can agree on a number, if they can, for cuts, then the next stage is going to the committees in the chambers, and that they have to come up with what that menu is in law. So there are a lot of lawmakers suggesting that, nope, we're not going to vote on, we're not going to make cuts that are going to hurt families. We're not going to make cuts that hurt benefits. It's very hard to think about hundreds of billions of dollars of cuts, certainly $880 billion of cuts that won't directly impact coverage levels and eligibility in states or benefits levels or payments rates. It would put states in the in the position of making decisions of what can we cut or what do we have to make up in state funds. And the magnitude is really hard to overstate. Next slide. So this is sort of when Kathryn talked about the per capita cap proposals or the capped proposals, this sort of illustrates what that would look like. So in the current financing system, which is open-ended on the left-hand side, you see that there's a federal share, and as costs go up, the federal share goes up as well, that FMAP rate that Kathryn mentioned. When it's capped and the costs go up for everyone that Ohio has agreed to cover, the additional cost is on the state. That's the blue you see on the right-hand side. So that's what we're trying to, in addition to just massive cuts, we could see a situation where we change the entire structure of how Medicaid's operated for 60 years, and that really would put states in a difficult position. Next slide. So if you just look at the money going into Ohio's state budget, if you look at federal and state combined is one way, but we looked at just the federal and just the state. If you just look at the federal numbers, Medicaid's nearly 70% of the money, federal money going into Ohio. So next slide. And then as you can see, if you just look at the state dollars, Medicaid's second, maybe even third, depending on the all other, right? It's actually second, but K-12 education is the first. That just shows you how much federal money is coming into the system and where the state would have to potentially make cuts if they wanted to keep up with that healthcare spending. Next slide. So just last week, the Kaiser Family Foundation they basically took the number 880 billion and said, if those are the cuts that went to the states, what would that be as a share of each state's education spending funding? So overall in the US, that would be a 19% cut if it just came out of education, and a per pupil cut in Ohio would be 28%. So if you just took it out of the education share, right, that's what that might look like, just for comparison purposes. Next slide. So some other research, this particular one also by Kaiser Family Foundation, has tried to estimate these different proposals that Kathryn went through and what the impact could be financially. So in this case, just on the per capita caps, it suggests that, Ohio could have to make up for 20 to 54 billion in spending. And if they chose to also reduce enrollment or eligibility, then the state would have to see a decrease in enrollment. Next slide. That's overall spending, I should say, federal and state. Urban Institute did something similar. We had similar proposals in the House and the Senate back in 2017. So they took some of those proposals, particularly the per capita caps and the expansion match drop, and said, all right, what would this mean if in the left-hand side of the Senate and then the House side, I believe on the right, were put into place. And you're looking at, again, big numbers in cost shift to Ohio, 42 to 65 billion, which is an increase in 30 to 45% of state spending, right? And potentially hard to make up. Next slide. So regardless of what the proposals look like, if Congress is trying to make cuts, and in this case, really, they're trying to meet numbers to offset some of the tax cuts they want to be doing for the Trump administration's priorities, they can't meet those numbers without cuts, however those cuts look like in that menu of proposals they're considering. And so that puts states, and particularly state lawmakers, in the really difficult position of deciding how to manage those cuts, right? They could boost state revenues, which is not typically a popular thing to do because it means raising taxes. In the Medicaid program, there are a lot of populations that are optional, so they could cut or cap enrollment in some of those optional populations. They could add more red tape to the enrollment system, which has a way of depressing enrollment. They could cut eligibility. I would say, a lot of children are actually optional children above some federal minimums. And so that would be they could reduce eligibility for children if they felt the need to. They could cut particular benefits or provider rates, right? Which we know are typically already lower than other health insurance payers. Or kind of as inferring, yeah, the other way, they could also look at ways to cut the state budget to make up for some of those costs. None of those are good options. Sometimes these proposals, particularly the caps, are sold as flexibility for states, but the only real flexibility states would have is where to make really hard cuts, really hard decisions. So lots of the things I've talked about and the data we've talked about are in resources that we have available. We try to pull out state information as much as we can, but that's where you can find us, and happy to answer questions. Thank you all for having me.
Okay, thank you, Guillermo, Kathryn, and Elizabeth, for your presentations this afternoon. We will now open the meeting up to any questions that you may have for the panel members.
All questions were answered.
I guess. Are there any questions? Okay. Well, if there are any questions, thank you all very much for joining us this afternoon. We certainly hope that you have obtained some information that you can take with you and utilize as we continue to have our conversations here in the state of Ohio with the budget proposals that are being presented on Medicaid. And that we can also utilize this information with our congressional delegation as they continue to consider changes to the Medicaid program at the federal level. I hope you all have a great afternoon. And again, thank you very much for joining us this afternoon. Will this presentation be available after the meeting? Yes, it will be. We will post it on the Ohio Legislative Children's Caucus website with the slide deck. Thank you, everybody. Have a great one.